Recording in progress.
Dear doctor, welcome you all to this presentation to osteoporotic patients. I am Dr. Srikanth K. consultant knee surgeon. These are my particularly work in Brighton Hospital, the birthplace of joint replacement surgery in the world. I was formerly a consultant trauma and joint replacement surgery in the UK, presently proprietor and MD of Southeast Specialty Orthopedic Center, Bangalore, India. I thank Ortho TV, Vira Global, and Gossi Global for giving me the opportunity to speak in this important meeting. For those who do not know me, I'm a consultant orthopedic surgeon, passionate about knee and hip surgery. I train in UK in all aspects of orthopedics and trauma, especially interested in computer-assisted, 3D augmented knee hip surgery, patient-specific implants, and robotics. Also have specialist interest in hip and knee, sports and revision surgery, for which I did a fellowship in A1 Orthopedic Center, Bristol, UK, and passionate about infected revision or septic revision, for which I run a quarterly referral service for India, having trained at the Mecca of single-stage infected revision, that is Endoclinic, Hamburg, Germany. I was a National Merit Scholar throughout in India, and I am very lucky to have worked in 4 out of 5 specialist orthopedic hospitals or centers of excellence in the UK, which is quite rare even for the local UK trainees. Today's subject, osteoporosis, a silent killer. So let's look at, what is osteoporosis? Osteoporosis is a porous bone. It's a devastating disease that robs its victims of the bone mass. A weak bone is difficult to fix. A weaker bone is difficult to fix the implant to, and not a good surface for implant fixation. And if it breaks, the fixation itself is very difficult because there's no hold for the screws and plates. So let's explore these fundamental concepts of both joint replacement surgery and osteoporosis in greater detail. So what are the surgical challenges in this very common orthopedic condition, osteoporosis? We know that arthritis affects around 20 million people in India. Knee replacement is known worldwide as a quality of life improving procedure. Osteoporosis is basically a neglected field. It's estimated that around 70 to 80% of osteoporosis is not treated even after surgery when patients come with wrist fracture or spine fracture or with hip fracture. It's well published now that 30 to 40% of orthoplasty patients have undiagnosed osteoporosis, and a number of papers have come in the last few years, even in the Asian population from Japan and South Korea, etc. We all know why a knee is called as a complex three-dimensional hinge, because it not only opens like a door hinge, but just imagine your doors, able to rotate on top of opening and closing, and you can see the complexity of the joint mechanism there. What are the conceptual changes in incidence and cause of failure of joint replacement surgery? We all know we started off with a hinged kind of knee, and then J-shaped kinematics. We're all very familiar as postgraduates reading about it. Then the concept moved to the transepicondylar axis. In the last 5 to 10 years after Hickhoff's work, the new concept of transcylindrical axis has come into place, which is the basis of the single axis radius knees, which are in the market. There's a great debate on what is the right alignment for the knee. Is it mechanical alignment, or adjusted mechanical alignment, or kinematic alignment, or adjusted kinematic alignment, or reverse kinematic alignment, or new kid in the block, the functional alignment. And we dealt with this in depth in my Center SSOC's 4th Meet the Master course, which is available online on Ortho TV. I refer you to this for further details. Also, we don't know if the knee pivots on a medial, that is on the MCL side, the medial pivot knees, and DGO has a lateral pivot knees, where it pivots on the lateral complex. There is also improvement in tribology. There is from normal poly, we have moved to ultra-high molecular weight polyethylene. We are using the thrice irradiated poly called X3. We moved to vitamin E poly, which is supposed to be as strong as metal. And we moved from stainless steel to titanium to cobalt chrome and armor coat on the femoral sides as well. So TKR in an aging active population who is obese is very challenging, and such patients are called millennial patients. You know that if somebody is above 75, they cycle their joints 1 into 10 to the power of 6 times per year. But if you look at younger patients less than 55, they do 7 into 10 to the power of 6, 7 times more. Hence, the revision rate is 1% per year in more than 75-year-old, but in less than 55, the revision rate is 2% per year. Means in 5 years' time, after TKR in a young person, 10%, that's 1 in 10, will come to you for revision knee surgery. So we all know about the indications for knee replacement surgery. We know the types of knee replacement surgery. Just want to focus on the newer concepts, that is computer-assisted surgery, 3D augmented surgery, PSA, and robotics. What are they achieving? They all lead to predictable accuracy, make surgery safe and recordable, and prepares better surgeons of tomorrow, because transparency and accountability is very important in medical practice. Total knee replacement, we all know about it. It's 48 years old. I was born in 1973, so it matches with the first knee being done in the hospital for special surgery. And those designs did have a good outcome, 94%, 15 years survival. The present generation of implants and techniques and technology has set the benchmark very high, 98% 10 years survival for the implants, and nearly 95% 20 years survival for the implants. So the bar is very high, but only 5% improvement that you can really make. Indian standards in orthoplasty or any surgery is make sure that the surgery is safe and the patient goes home safely. That is the standard. I was in a meeting with Prof. Malhotra when he was IOA president, and he talked about how to ensure quality of life. He was talking about FFM basically. And I think we, as a nation, we have to move there as a nation. Quality more important than quantity. We have to move from patients going home safely to our implants in our patients lasting for 15, 20 years, which is what the Western literature is proving. And that is a real success. Just that the patient walked after our surgery is no longer a proof of our success, as we commonly have set that as a benchmark. What are the prevalent common myths or common prevalent myths? Eyeballing is better than technology. So I've been using robotics for the last 1 year, and I'm 48 years old, as I said. And I can safely say that, I don't think my eyes can be accurate to 1 millimeter. It can't even differentiate, 1 millimeter accuracy. With robot, use 1 millimeter accuracy. I think this debate is destroyed by the robot, which basically stops cutting with your outside 1 millimeter of your haptic boundaries. Second is one size fits all. We know that every knee is unique. They are not the same. Bilateral knee and hip replacements are better than stage procedures. It's a very controversial and litigious area, and it needs a day's debate. I will not even go into that. And I was in a meeting a few years ago with Prof. Ross Crawford, who's a professor of Mako Robotics, Australia. And he said about India that in India we put commercial interest above science. And he was referring to the widespread use of uncemented stem in India, despite the proof contrary to that, and cemented stems doing well worldwide. And looking at an X-ray and doing a total knee replacement in 2022 is basically providing a 2-dimensional solution to the knee, which is a 3-dimensional problem. Other common myths in India when I moved here is that anybody can do a knee and hip replacement. And it's very surprising that this came from some of the top corporate CEOs in the country. And I didn't understand at that time. I was thinking, what about the patient? But all the corporate people, the heads, the leadership, they had this concept of EBDT, earning before deduction of tax and other expenses or allowance. So, if you can get an Ayush doctor to do a knee replacement or a hip replacement surgery, then you can pay in pittance. And, the amount of money the hospital makes is huge amount, comparing to paying a specialist or a super specialist. And I think from a business point of view, they're completely right, but they are completely wrong from a patient point of view. Even in UK, my trainees, my registrars felt the same. And they all said, Mr. Srikanth, what's so big deal about knee replacement? Just open the knee, put the jigs, cut the bone, fashion an implant, close it up, finished. Bob is your uncle, as they say in UK. I mean, so these two concepts are far from true, and I'll explain why they're far from true. This is Dr. John Insall. Professor Insall is a father of knee replacement surgery, as we all know. And he told us and taught us that Knee replacement is a soft tissue procedure, not a bony operation. Why did he say so? Because he understood way back in 1973 the importance of the role of ligaments in the knee. So let's look at it in a bit detail. We know the primary restraint to anterior translation of femur and tibia is by the ACL. Secondarily, the restraint by the ITB, medial lateral capsule, medial collateral, and lateral collateral ligament. Posterior restraint is typically PCL, but also by MCL. Interrotation is restrained primarily by ACL, but secondarily by PMC, posterior medial complex. External rotation, we know at 30 degrees is restricted by posterolateral complex and at 90 degrees by PCL, but this is a dial test, and MCL at all angles. Valgus at 30 degrees flexion is restricted by superficial MCL, secondarily by ACL, whereas by NCL at 30 degrees and secondarily by ACL. So ligaments are doing multiple functions. We know the 6 degrees of freedom of knee, all of us know about this. And to do a knee replacement, you need a 3 basic cut: tibia, femur cut, and a patellar cut. If you add these 3 cuts to 6 degrees of freedom, there's 215 ways in which a senior orthoplastic surgeon can get a knee replacement wrong. What to speak of an Ayush doctor doing a knee replacement surgery, to increase the EBDTA for a hospital. So I answered the question of the real myths in India. A clear no if you have patients' interest at your heart. Fundamental principle of ethics is tribal non sere, first do no harm. So a proper training experience is a must. So the modern concepts of navigation, 3D augmented knee, patient-specific implants, and robotics have come. You know why he is the best in the world? Because you can measure what Usain Bolt has done, 100 meters and 200 meters. These are the records. What are the limitations of the human eye? Eyeballing can't differentiate less than 10 degrees of change in angulation. More than 6 degrees change in varus valgus alignment leads to a catastrophic failure of the acute knee replacement. You don't want a bad day at office to affect the outcome of your patient surgery. You want to minimize surgeon error when so many factors at play, some known and many unknown, like the role of ligaments. Let's add this concepts, of the basic concepts of knee replacement surgery to osteoporosis. And let's see what is the spin it takes. We now have understood that knee is a complex three-dimensional hinge. The alignment versus balance in a knee, that debate is still going on in 2022, which is more important. Which alignment is it? Mechanical, adjusted mechanical, adjusted kinematic, or reverse kinematic, or functional? Is still being debated. More and more we are going towards functional knee alignment as a right, and functional alignment is almost impossible without using advanced technology like robotics. Role of all ligaments are not understood, as I put it, and eyeballing only gives a 2-dimensional solution to a 3-dimensional problem. Osteoporosis, leads to poor fixation surface. It causes increased periprosthetic fracture if you bash in an implant. And once you've broken the femur or tibia or patella, it's extremely difficult to fix these fractures because the screws don't get the hold in an osteoporotic weak bone. So what are the solutions in an osteoporotic bone? I think proper preoperative evaluation and planning is a must. If you fail to plan, if you fail to prepare, you prepare to fail. This is a fundamental principle. We need to do additional tests like bone profile, parathyroid hormone levels, TFT, vitamin D levels, etc. When you do a total knee replacement, you need to put a stemmed implants with cement, which is a must. You need to have patience, no 10 minutes total knee replacement, So there's less role for uncemented TKRs in osteoporotic bone. If you're doing THRs, there's definitely no role for uncemented implants. You can't bash them in, you break. 30 to 40% is the incidence of femoral fractures in uncemented THR. Neck of femur also, there's no evidence for uncemented bipolar, maybe used commonly in India. If you look at the classic review article from Oliver Guin in 2019, he clearly says in elderly patients with poor mobility, in a neck of femur, cemented unipolar by anterolateral approach, in a mobile composite disc patient, cemented THR by a posterior approach, or if you got suspect stability of the hip, use a dual mobility. And this should be done by expert hip surgeon. It should not be done, for example, in UK, in a district general hospital, you can't, a foot and ankle specialist can't do this. You need to wait for a Monday for, hip specialist to come and do this job. Similarly, in India also the same principle applies. I had a number of patients who called me from distance like Hyderabad and even periphery of Bangalore, and they had neck of femur, young patients, dads 60, 65, 70 years. And they said, doctor, what needs to be done? I said, this is a hip replacement. And then, they said they will come, and then, a week later, they had got to the local doctors there and got a surgery done. And they send me pictures. Sir, we had a hip replacement, and just look at it, how beautifully it's done. And what I could see was a uncemented osteoporosis prosthesis being pulled as a hip replacement surgery. I was shocked, but many of these patients were lawyers, and I had to keep my mouth shut and just swallow, as they say, hot ghee in my native language, and keep quiet. So this is what is happening. So this should be avoided. Walking plates has become a game changer with the use of teriparatide in this particular scenario. Post-op, very important. Osteoporotic treatment is a must. I think, more and more will become negligent if we don't treat osteoporosis. And we should use calcium, vitamin D if there's deficiency, teriparatide. There's more evidence is coming for its extended use. It's not just, I think US FDA has also approved use of teriparatide, not only for osteoporosis, postmenopausal osteoporosis, but as an extended indication in fracture healing and in osteoporosis and periprosthetic fractures. Zoledronate, very useful, cheap, and but it does increase the BMD for a short time, but there's increased side effects like jaw necrosis and the atypical fractures in the femur, which you should be aware of. Denosumab, it's osteoclastic agent, very good, subcutaneous, 6-monthly dose. There's good evidence to show the BMD around the process increases in tibia up to 6 months and in femur up to 12 months. And beyond 12 months, it's not found to increase the BMD. So I think there's more and more research coming on that, rather than stimulation of osteoclast inhibition will be an important factor in preventing periprosthetic loosening. And as I mentioned, not following evidence-based medicine can lead to negligence. We know that the average cost of litigation per patient in India is about 5 crores now. Not many doctors know about this. And I think future we should have a low threshold for using navigation, patient-specific implants, 3D, augmented knees or robotic surgery. Basically, when you're good at it, it reduces the op time. It reduces bleeding. I've almost stopped blood transfusion in all my robotic patients. Trace usage comes down from many 6 to 8 to a few. And eventually, there's a reduced cost of revision burden. Revision surgery is very expensive. And minimally invasive surgery may be possible, and knees can become truly patient specific. So it leads to better functional outcome, and forgotten needs is the holy grail of knee revision surgery. I'll not go to this, deal with some of these complex cases that I had to deal when I moved to India. These are osteoporosis and knee surgery and lessons that one can learn. Case one is a 66-year-old lady, 120 kg diabetic, operated by the top 2 orthoplastic surgeons of the state. Unfortunately, got infected. After 5 surgeries, the primary surgeon gave up. He left her with no joint, and she was in a bedridden state. Her daughter came to me 2 years after this, and this is how she came to me on the right-hand side. And the issue she had was morbid obesity, diabetes mellitus. I think the quadriceps had ruptured in one of the operations, and he had, repaired it. And there was 5 failed surgeries, and the multiple scars, as you know, which are marked there. And I think in the last but surgery, the surgeon was not able to close the wound. So I asked his plastic surgical colleague who had come and done a gastromerial flap. So I knew only one flap was left if I get into trouble. And the shortening of 1 inch, you can see I'm demonstrating that. And she needed a bariatric table and a bowl anesthetist to take it on. So the plan, we grew the bucks. The revision was planned in 2 stages. First stage, I put an antibody fluid cement spacer, a proper antibiogram. ESR became normal 8 weeks. Further aspiration was negative for bucks. Second stage had to be done in a super specialty hospital because it needed all the backup. It was combined orthoplastics workup and teamwork. I had to get clearance from quite a lot of senior guys, physician, nephrologist, cardiologist, vascular surgeon, and anesthetist. And it was a challenging surgery. It lasted for 4.5 to 5 hours. Massive fluid shift. Spent 24 hours in ICU, and the quality of quadriceps was poor despite the rectus snip, and that had to be addressed. For many more challenges, we put in a cemented stem with the metaphyseal only cementing. You see that, it's very important. The reason that's important is because recently one of the senior doctors in Bangalore had in a same infected division had cemented the whole stem as well. And then what happened was after 3 weeks after this surgery, the second surgery, the knee got again infected, pouring pus, and he didn't know what to do because it cemented the stem. There's no Oscar in India, so he had to split the femur and tibia. and he had to fuse the knee, which is not really good. So this lady, walked. Then the money went. This is another osteoporotic challenge. You can see a pathological fracture dislocation. The patients were poor. They didn't offer a knee surgery or a knee replacement surgery. So I'll skip this. This is an interesting thing. Unfortunately, of the exam, my examiners always to say, Shri, if I need to pass you have to show me that you are safe to operate on my mother, not my mother-in-law. And they used to laugh. And, very strangely, after I moved to India, I ended up operating on my own mother. This is her X-ray on the right-hand side. I had a senior surgeon with me because it's never good to operate on your own relatives. And then when we started after this final, he said, sir, you are senior yourself, so why don't you start? And then, as the anesthesia was saying, I just started for 5 minutes. I hesitated. And after 5 minutes, I was so much involved in surgery, I completely forgot that it was my mother. And she had osteoporosis. And you could see on the tibial side, I had to use a stem extender and cement the metaphyseal region. So she's awaiting the other side in the next few months. Coming to osteoporosis and robotics, I started robotics since the last year, and I think most robotic systems have this navigation pins where you place a tracker for the robotic to track, especially where the knee is or the hip is. So this is my last patient whom I did a robotic. She had a suspected osteoporosis, and after admission on bedside, confirmed that she had a, osteoporosis. And during the femoral anterior pin placement, once the tracker pin had gone past the anterofemoral cortex and hit the posterofemoral cortex, the anterofemoral cortex got a blister and it cracked around 5 millimeters. So almost my heart stopped, and I had to feel that I'm not broken the femur and put my hand all around the proximal femur around the pin to ensure that there's no periprosthetic fracture. So then, we went ahead with very careful, surgery. Not trying to stress and not trying to be very quick and brave. And this was definitely a consequence of osteoporosis. And you could see that anterior cortex hole, which got created because of things. We did put a bit of bone graft in the end and close it up. And this was immediate post-op access. So I was not happy. I wanted a longer view. So I got this lateral repeated really. And yes, so despite this issue, she got a perfectly balanced knee from 0 to 120 degrees post-implantation. I can just see that the blue and the orange blocks there, just 1 millimeter gap from 0 to 120 throughout the range, perfectly balanced knee and aligned as well with almost 1 degree variance. So osteoporosis robotics, as mentioned, I checked the femur, it was not broken. The whole surgery had to be done carefully to avoid an intra-periprosthetic fracture. Post-op, I put on teriparatide. I kept her partial weight bearing for 2 weeks and full weight bearing afterwards. She had good recovery in 8 weeks' time, and she did achieve, I saw a few weeks ago, she did achieve a good range of movement. I think there's a video there which didn't work. I think the video is not working. Basically, she's able to SLR and bend the knee up to 80 degrees straight post-op in the recovery. So my take-home messages is that total knee replacement in hospital patient is like complex primary knee replacement surgery. You need to plan and need to have patience, and that's very crucial. And training is a must to perform these complex work to acceptable standards. And those choose cemented total replacement with stems. Be gentle with the bone. No need to bash the implant. Be aware of impending periprosthetic fracture, like in a robotic case. And the cuts are press fit, and you basically can extend the knee after cementing to pressurize the cement rather than bashing the implant multiple number of times. I know my junior during the restart time, the guys hit it and he just broke the femur in a very strong bone, not even osteoporotic bone, so it can happen. So don't forget the basics. Cement is not a glue. But it's a grout, and it's strong in compression, it's weak in shear and torsion. So you need to understand this. If you don't understand this, please don't do arthroplasty. So don't rush. That's the key thing. Surgery is not a race against time. For you, it may be one patient. For that patient, it's it's one surgery for our life. So, and if you're a junior, it should not be performed by novice by watching OMD and things like that. You need to seek senior help. And India is one of the most hostile judicial environment in the world. I work with a lot of senior lawyers in the country, and average compensation is around 5 crores per case in 2022. And it's not a small amount for anyone. When things go wrong, you will get roasted, and with this amount of compensation, probably broke. And here in India, you get jousted as well if something goes wrong. These things spread, negativity spreads faster. So the popular saying in UK is that when in doubt, refer to appropriate trained specialist or seek, combined work. You just call the seniors and they're more than happy to help you. They don't want to leave you high and dry like this. So this is osteoporosis in hip. This is immediate post-op following hip replacement in osteoporotic patient. And you really don't want this kind of thing. Either you want, or the patient want, or the hospital administrator want this. So what is the evidence, with hip surgery? And if you look at the meta-analysis and of all the osteopaths in 2017, cemented total hip replacement, last 88% 15 years survival in above 75 years old. This is New Zealand registry 2017. Cemented stem, third generation cementing, excellent long-term results in all age groups, well proved in papers from Exeter 2018. Cemented cup has poor results in below 50 and 50 to 75 years, where you can use a hybrid system, where an uncemented cup and a cemented stem. Least post-op pain, least dislocation, least infection, least periprosthetic fracture, least revision by cemented. Uncemented, good survival rate in less than 50 years old, particularly on the femoral side, lesser revision rate after 7 years post-op compared to cemented. In more than 75 years old in females, 30% periprosthetic fracture rate. Thigh pain, subsidence, dislocation, infection, leading to revision. These are all the problems with uncemented. So I can safely say there is no role for uncemented stems in total hip replacement in geriatric patients. Increased uncemented use is not backed by evidence or health economics, but pushed by the industry. So to conclude, I'd say that from the 5 annual reports of international joint replacement registries and systematic reviews, cemented THR is good long-term survivorship, 89% 15 years, and cementless fixation, 86% at 15 years in primary hip arthroplasty. Cement THR survive better in older patients, and cementless fixation better in younger patients, and particularly in the femur. And periprosthetic fracture were more common in the cementless fixation. So such risk should be informed to patients before surgery, the chance of periprosthetic fracture and the percentage of the fracture. So older patients with cementless fixation increase the risk of revision. There is no clear fixation advantage in middle-aged patients. Complication of DHA can lead to burden on healthcare, burden on patients. In 2022, there's no role for uncemented THR in the geriatric population. So get it right first time. I think I'll leave you with a quote from John Howell from Exeter, why he still uses cemented THR. It has got a 50-year history. Cemented components also offer important benefits like ability to restore patient's anatomy, most importantly, offset leg length and component position as independent variables. Never happens in uncemented stem. It goes where it goes. The fine control that they offer helps to tailor each operation to the individual needs and thereby achieve the best result possible for every patient. In the long term, the presence of well-fixed cement mantle offer opportunity for the cement in cement revision if further surgery is required. Components can be considered to be modular at the processes, cement interface, and the technique allows the surgeon to revise and return a patient to their primary state. And we had a fantastic debate with Professor Alistair Hart, chair of UCL College London, and my boss, ex-boss, Dr. Edward Smith, the European head of UK head of European Society, about the 3D printed implants. And Professor Hart made a very important comment 2 years ago in the center's third Meet the Masters course. And he clearly said after all the evidence and research that he has done, cemented stem is the best in the femur. And my boss having designed uncemented stems, it was a big thing to swallow, but the heart goes by evidence, and that's something which all of us as surgeons, juniors and seniors, have to open our eyes and look at evidence and follow the evidence. So thank you very much. This is my reference for a talk. Thank you very much for the patient. So these are my details. If anybody wants to contact me, I'm more than happy. Team is happy to help you. So I seek your support to serve these patients better. This is how to contact me in what time there I am present.